Hello, and welcome to the second lecture in the Clinical Correlations Female Reproductive Systems series. I'm Matt Karen, and I will once again be taking you on a female reproductive journey. There are 12 objectives for this lecture, 10 cognitive and 2 affective, and as always, feel free to reach out if you have any questions on objectives. So let's pick up where we left off and start with the uterus. Now would be a great time to go back and review the anatomy and embryology from the first female reproductive lecture. Feel free to go ahead and do that now. Now that you've thoroughly reviewed the embryology and anatomy, let's talk about some of the benign pathologies. First up is adenomyosis. Now this is a very specific type of endometriosis, which we'll talk about shortly. But in this case, we'll see endometrial glands actually inside the myometrium. Now, if you recall, the myometrium is predominantly smooth muscle. So this is not a place where we want our glands. Typically on the cut surface, the myometrium is going to look cystic and trabeculated, as you see here. And that might be an incidental finding you find on any uterus who grows. The thing to remember too is these endometrial glands are actually going to be responsive to the same hormones as the endometrial lining. So we'll see some changes take place in the myometrium that are not usually welcomed, and this can cause pelvic pain in the female as well. This means we'll also possibly see some hemorrhagic material in some of these cysts on the cut surface. Now, endometriosis in general is actually ectopic endometrial tissue, which is found outside the endometrial cavity. So this will include not only just the glandular components, but the stromal components as well. And this is something that you'll see in about 10% of women. Now, this actually will present as a sort of powder burn looking appearance on any sort of serosal covering. So sometimes when you're doing a hysterectomy, this is something you'll look for on the outer serosal surface there. These commonly occur, or the endometriosis that commonly occurs, in the sites listed here, beginning with the ovaries, uterine ligaments, and then some of the other pelvic cavities listed here. Some of the things you'll note with this is infertility, dysmenorrhea, and pelvic pain. And part of that is a result of the fact that these endometrial glands are still responding to the hormones, such as follicle-stimulating hormone and luteinizing hormone, the estrogen and progesterone, and those things that are going to promote the uterine cycle. So when those cycles are actually occurring outside of the endometrial cavity, that can be very problematic. Another condition to be mindful of is uterine prolapse. This is something that you might see as a benign hysterectomy that you get. And what happens is that the uterine ligaments are going to actually be weakened. And so that means we'll probably lose attachments at the round ligament, as well as potentially maybe in the suspensory ligament, which is holding the tubes and ovaries in place. Or sorry, I should just say the ovaries. With the weakening of those ligaments, we actually see that the uterus, which should normally be tilted anteriorly, is now a little loose and can kind of fall back posteriorly, and even worse, in some extreme cases, descend into the vaginal canal. This is associated with menopausal women, or postmenopausal, I should say, as well as like chronic constipation, any sort of increase in abdominal pressure, low estrogen levels, which is part of the postmenopause, and as well as obesity too. So sometimes you'll just get a prolapsed uterus and it should look relatively normal. On the other hand, there's also endometrial polyps. So these don't really have a known etiology. These are just something that you might see. But there is an association with tamoxifen use, which is a breast cancer treatment drug. And there's also responsiveness to estrogen, which when you get to the breast cancer lecture, you'll see why that makes sense. So what we see here is just a benign overgrowth of endometrium. So this is just more of a hyperplasia element, but in a very specific polyploid area. These can typically be easily removed with a curettage, although if they're very large, maybe obstructive, these might require a hysterectomy. Endometrial polyps are not as common, but something you'll probably always see is a leiomyoma, or leiomyomata, which is the plural. So these are going to be benign proliferations of smooth muscle, and we typically classify these as having a tan-white whorled cut surface, that whorled being the key word there, so that's kind of synonymous with a lot of smooth muscle tumors. We do classify these into 3 types, so a lot of places might, when you're dictating, actually like you to kind of indicate or describe a little bit more what the location of these leiomyoma are. So you could be subserosal, which in that case you'll actually see it just underneath the lining here, so you can kind of see the subserosal one bulging, but still sort of superficial to the myometrium. Then you'll have the intramural, which are kind of completely surrounded by your myometrium, and then submucosal, which will have the endometrium on one side and the myometrium on the other. So do your best if you can when you get these to try to describe them, but otherwise, I mean, these are relatively common. You'll probably just see them as incidental findings. One thing of note is you'll hear the term fibroids and leiomyoma kind of used interchangeably, and that's perfectly fine. But if you want to get technical, usually fibroids are something more associated with postmenopausal women because the leiomyomas are a little more fibrous in nature rather than smooth muscles. That again goes with the postmenopausal sort of experience there. So use either term, fibroid or leiomyoma. They're both perfectly acceptable, but if you're ever curious what the true difference is, there you have it. The other thing to watch out for that can look kind of scary is these degenerative leiomyomas. Now, leiomyomas themselves are fairly benign. They can be obstructive or cause additional abnormal bleeding. And it's important to note that the leiomyoma, I should say, don't evolve into the leiomyosarcoma, the malignant version, which we'll talk about in just a moment. But in between, you have these degenerative leiomyomas, and these are fast-growing tumors. But what's interesting is they're growing fast and relatively well controlled. And so what you see is the tumor itself kind of realizes it's growing past its blood supply. And usually if it's a malignant tumor, it just says, blood supply be damned, let's grow as fast as we can, and things just happen to necrose after that. But if there's a little bit of control and the tumor cells realize they're not going to be able to maintain the size of that tumor, they can do what's known as cystic degeneration. And that's where the cells undergo apoptosis and are more controlled with their death rather than just the necrotic or the necrosis that you'll see with advanced tumors. So you have a more controlled sort of de-evolution of the tumor body here. You can see hemorrhage and necrosis in some extreme cases. Again, that might be just incidental, but these should not be invasive, and they should not lead to leiomyosarcomas. And I actually want to bet with a pathologist because I was able to identify these that he thought was a leiomyosarcoma. So yay, go me. So the leiomyosarcomas, or the malignant version of those tumors, they actually occur de novo, which means they basically just arise as their own tumor. They are not there's no precursors like we see with some cancers. So if someone has a leiomyosarcoma, there was no previous leiomyoma that would have evolved to that. So that's something they kind of take some solace in because those leiomyomas are very common, or say leiomonomata are fairly common. So you don't want those to eventually evolve into cancer. So these will be nice little pink fleshy masses here. You can kind of see some hemorrhage and necrosis, and they can be locally invasive. So you'd stage these very similar to other uterine tumors as well. Another fairly uncommon tumor is the carcinosarcoma, or what is formerly known as the malignant mixed mullerian tumor, or MMMT. They don't really call it that anymore because it really doesn't say anything. But if you notice the words here, carcino and sarcoma, so carcino is usually an epithelial tumor. Sarcomas tend to be mesodermal tumors. So here's a tumor where you have mixed elements. So you might have malignant fibroblasts or spindle cells mixed with epithelial cells. Again, these are relatively rare and can present as pretty bulky and polyploid tumors. But despite the rareness, they are fairly aggressive, and there's a very low survival rate, as you see here. So something to be mindful of. But again, I've not seen one of these, and they're fairly rare. So if you ever get one in clinicals, it might be worth writing up a case report for. Now, when we're talking about the primary cancer of the uterus, we're really talking about endometrial carcinoma. And that starts with endometrial hyperplasia. So if you recall, we talked about cervical dysplasia last time, which was a precursor to cervical cancer, specifically squamous cell carcinoma. Well, endometrial cancer is not squamous cell carcinoma. It's adenocarcinoma. It's of the glands. and its precursor lesion is actually a result of hyperplasia. So what we'll see here is, depending on the atypia of the cells, and kind of the presentation of this atypia, we can, or the pathologist would rate the hyperplasia and dysplasia or atypia accordingly. So you could have a simple versus complex with prominent atypia or very little atypia as well. So based on that grading, we can kind of get an idea of the extent of the hyperplasia. Obviously, the more atypical and the more complex, the more likely it will evolve into cancer here. Some of the causes associated with endometrial hyperplasia here are actually very similar to what we saw with some of the other pathologies, particularly things like the prolapse. So when we have stuff like menopause or estrogen therapy, things like that that are really responsive, this is going to, or the estrogen therapy that's responsive to the endometrial lining, what you'll see is this can cause sort of an unnatural proliferation, things like that, that can ultimately lead to that hyperplasia association. And if left kind of untreated or unmanaged or just very unlucky, the endometrial hyperplasia can eventually evolve into endometrial carcinoma. So a couple of big things about endometrial carcinoma. This is a fairly late decade tumor, so common median age of diagnosis being 63, with a 7-year survival rate on average. Now that seems, what should we say, not great. But one thing to point out is the 5-year survival rate for endometrial carcinomas are fairly good. If these tumors are caught early enough and treated, there's actually a 90% survival rate, and an 81% in general. But that 81% is kind of taking into account like all tumors, because realistically, it really depends on what type of endometrial carcinoma we're talking about here. So we have two types. There's an endometrioid type or a serous type. The endometrioid type is the most common one we'll see, and this is the one that you can classically think of when we think of endometrial carcinomas, which I'm sure you all do a lot. But this is the one that you'll see as an exophytic mass. It might be infiltrative to the myometrium as well. Overall, the cells will look kind of like a normal endometrium, and this is the one that follows that endometrial hyperplasia route until it gets to carcinoma. So the risks for hyperplasia are identical to risks for carcinoma. So again, having any sort of diabetes, obesity, which obesity tends to increase levels of estrogen. So the adipose tissue in the body is chock full of like androgens and lipids, which is kind of the building blocks of estrogen. And the other type that we have is the serous type. And so this one's more of a papillary looking tumor, both histologically and grossly. It's not one that you'll see often, and really the only association is actually a tumor mutation or tumor gene mutation, the TP53, which you will recall from pathology is associated with a lot of tumors. So again, depending on the type will ultimately dictate the survivability. And usually when we're talking about endometrial carcinomas, you can go ahead and assume endometrioid type going forward. So here's what endometrioid type looks like. This is kind of your basic presentation. You have this nice exophytic mass here. Pay no attention to this image. I don't know why I include it. Usually I get angry looking at the way the uterus was cut. So uterus should not be cut anteriorly. That's awful. It just makes it very difficult. And this is likely a surgeon that did that just because they wanted to see the tumor. Couldn't wait for it to get to pathology. But what you'll notice is a very exophilic appearance, and these tumors might be friable and kind of hard to sort of visualize the boundaries because they're going to kind of cover both the anterior and posterior walls. That's why it's usually good to bisect these completely. You also want a serially section because we're going to look for this invasion here, and we'll talk about that in just a moment, but we're really interested in doing myometrial invasion at the time of an intraoperative consult. So it's likely when you get a uterus for a frozen section, you'll have to find the deepest point of invasion and submit that for reading. Okay, so speaking of intraoperative consultations, now when you do get a uterus for a tumor that you're interested in looking at the depth of invasion, it's really important that you serially section and look and find, I should say, the deepest point of invasion. And when you're measuring that, you're going to have to try to identify your endometrial lining and where that is on average. And that will be the starting point for measuring your depth from that point into the myometrium below. So if you look at this one here, let's see if we can get our little image here. So it looks like we could argue our endometrial layer is probably right about there, which means if we're looking at depth of invasion, we would measure it from that point all the way down there. So that's our invasion into the myometrium. So this is going to be something that you'll do quite often in the Surg Path Lab and in clinicals, and this is what it will be a common frozen section that you'll be doing. So it means you're going to have to get really proficient at sectioning these, which won't take too long, and it can also be stressful the first couple of times. But the reason we're doing this is, and I'll talk about staging when we get there in a little bit, this is going to be the exception to my A and B rules. But we're looking for invasion because this is going to dictate what else we're going to do in surgery. So when we look at the myometrium, most of the vasculature is found in this sort of peripheral half, so the lower 50% of the myometrial wall that contains a lot of your vasculature. So theoretically, if the tumor invades that far past the 50% mark, there's a greater risk that it's in the blood supply and has actually made it to the pelvic and periotic lymph nodes, as well as maybe some of the other surrounding structures. So at that point, the surgeon is probably going to go and do some debulking or staging resections just to make sure there's no other tumor present. They're going to get some lymph nodes for us to look at as well. So when we're doing that, we'll calculate the difference. And basically what you do is you measure your entire myometrial thickness. So if we're going to do that, let's say my entire myometrial thickness is this green line. And then I would just compare, let's say it looks like it's about a third. So let's say this is 3 centimeters for my myometrial thickness, and the tumor invades 1 centimeter out of 3 centimeters. So in that case, we would be below the 50% cutoff. So that the tumor would likely be good, and they wouldn't have to go back and stage the patient any further because there's likely no spread or hopefully no spread. Not always a guarantee, obviously, but that's kind of the way they base it in the OR. So let's take a look at some of the surgical specimens you'll get as related to the uterus. So biopsies are a thing. So we talked about endocervical curettages. You can also get endometrial curettages. Remember, that's the primary treatment for a polyp. Morcellations, which you'll grow to curse and hate. Hysterectomies, we have several types. And this are typically done for any sort of hyperplasia or cancer, prolapse, and maybe just prophylactic. But we have a couple types that I'll mention in a moment. And then finally, the pelvic exoneration, which you can also see in cervical cancer. So I mentioned that last week, and we'll look at that again shortly. But the pelvic exoneration is for really advanced stage diseases, and you're going to pretty much get out all the pelvic contents that include portions of colon, bladder, and the uterus, with varying extents depending on the disease there. So the types of hysterectomies you're going to get, sometimes you might get a subtotal where the cervix is left intact, and that's usually done for individuals who are younger and they want to kind of maintain the integrity of the vaginal canal. Obviously, there's no longer going to be a fertility concern, but at least with the cervix intact, it kind of limits the gaps, we'll say there. The other common one you'll see is a total, which includes basically your fundus and body of uterus with the cervix attached, and that's your total. And then you'll get your radical. Now, technically, a radical doesn't include the right and left adnexa. When we say the adnexa, that usually implies the fallopian tube, ovary, and attached kind of mesoovarium and mesosalpinx, which is part of the broad ligament. The radical instead will definitely include the fundus with the body, cervix as well, portions of vaginal mucosa, and then that left and right perimetrium that we mentioned last week, which is pretty prominent. So we'll talk about those in a little bit because we talked a little bit about how we do radical hysterectomies for the cervix. They can also be done for the endometrial cancer as well. So for an endometrial curettage, basically you're just going to get fragments of tan pink tissue. There might be an aggregate of blood present, and these are usually received on like a little Tefla pad that was used to help scrape it off. So again, just like endocervical curetages, It's really not a great idea to freeze these specimens. They should be submitted in formalin processing and, or sort of, we'll just say normal formalin processing. So you want to make sure everything's submitted, measure it in 3D, and just do like you normally would with the biopsy. Usually I'll take like a scalpel, a fresh scalpel, and then like just kind of scrape along the paper that it's received on just to make sure I'm getting everything. Now, the morcellated uterus, this is a procedure where they'll actually go through and try to fragment. The idea is to fragment fibroids, especially very large fibroids with small incisions. Now, this is actually becoming a less common surgery, thankfully, because it tends to be, it increases the likelihood of spread if there is tumors present. So unless the candidate has been thoroughly, we'll say, vetted to make sure there's no risks of cancer or any concerns of potential seeding, it could be a problematic procedure in that regard. It's also problematic if you get this and there's a potential for cancer or even identified cancer, because what you're going to see if you look in the pan here is a cool little pointer. What you see here is just fragments of uterine tissue. Some of that is going to be myometrium, some of that is going to be leiomyoma. You might have some endometrial tissue present. You'll see some bits of cervix, maybe a fallopian tube in there. And your goal is to find all of those. So just like you would when we talk about a uterus submission and the different parts, you're going to have to make sure you find all those representative parts in your morcellated uterus. So I thoroughly hate these specimens, and most people do as well. I'm just assuming so. So I'm going to assume you guys will hate them also. So an interesting finding that's not really a pathology per se is this Asherman syndrome. I didn't learn about this until I was out in the field a little bit. But what you'll find is sometimes you might get a hysterectomy from an older patient or a patient who may have had a long-standing medical history. And the endometrial lining, especially you try to probe it, and it's just very hard to kind of separate the endometrium. It just feels like it's fused or fibrous, or it feels like there's a cancer in there, but there really isn't. And what's actually happening is there's just a prominent scarring, and this is due to multiple procedures like curettage and dilation. So women who are constantly getting biopsied, they might see endometrial lining get scarred and start becoming adhesive. So this is just something worth documenting. You don't even have to call it Asherman syndrome, but if you want to sound cool and smart, you can. It just might be something you see when you're grossing your hysterectomies. All right, so last week I told you we didn't have to necessarily worry about hysterectomies until the following week. Well, now it's the following week, so we have to worry about them a little bit. That being said, I kind of mentioned that it has like a flow chart, and I'll upload a separate kind of compilation of all these the prosection routes, we'll call them. But depending on what you receive the uterus for, it will dictate kind of how you approach the specimen. It's just slight variations. But I'll encourage you to try to get the basics down first, and what are the main primary sections to look for, and then you can kind of branch off of that. So first, we get our hysterectomy, and we're going to weigh and measure this. So first, you'll try to keep orientation when you're measuring 3D. So I usually do like a anterior to posterior measurement, fundus to os measurement, and a cornu to cornu. So you remember the cornus are where the fallopian tubes come in. We're also going to describe the outer surface. That's pretty standard, so the SSCCPT. Things to look for are some nodular defects. We can look or identify our subserosal nodules at this point. We don't know if they're fibroids or not. We also want to verify whether there is attached tube and ovaries, or if they're in the container, or if they're not contained at all. This is something worth noting because sometimes they'll say tubes and ovaries, but they won't be there. And basically you want to look for what should be known as a total abdominal hysterectomy, THA, and with bilateral salpingo orophorectomy. So THA BSO is the common procedure. So if they say that, you should have a total hysterectomy with tubes and ovaries either attached or in the bucket. And it's happened, it's not uncommon. We'll say that I've gotten either tubes and ovaries when they weren't mentioned, or you didn't expect them, or they were indicated but they weren't in the container. So something worth looking at. You'll also want to verify whether there's attached perimetrium and vaginal mucosa. Now that should be for radical resections only, but again, if they just say hysterectomy or total, you got to just do your due diligence and assume maybe they are just taking the shortcuts. This is also a good time to look for that powder burn like appearance that's consistent with endometriosis. You might see that on the outer surface, and that's worth sampling. This is also a good time to ink. So if you recall, when we're orienting our uterus, we have the party in the back with the peritoneal reflection, and then we'll have more of that stromal adventitia of the cervical neck on the anterior side. So you can ink that anterior versus posterior if you'd like, or just one color. Again, if you're keeping your uterine halves separate, it's also doable. So typically uterine carcinomas, because they're contained within the endometrial cavity, which is predominantly covered by serosa, it's not common for places to ink those. I never really inked my endometrial carcinomas, but again, you're never wrong for inking just for cautionary sake. Next, you're going to probe the os, and this is where you want to document what the os looks like. So if the os has been untouched, no pregnancy or no vaginal delivery, it should be a pinpoint os. But once a woman has delivered a vaginal birth, the os will now be slit-like, so you can just measure that diameter, whether it's a pinpoint or slit-like. And then you're going to stick a probe in there. I actually like sticking forceps in there to kind of guide you. So I'll do a nice long pair of forceps, stick it in the cervical os. Hopefully it's patent. You can describe that as you go in there. And then I can take a scalpel and bisect that. Some people use scissors too to do that, but kind of personal preference. So as you're doing that, we're going to look at our endometrial cavity. We want to measure that typically in 2 dimensions, and our endocervical cavity also in 2 dimensions. So you can just do a length by width, I guess, would be that. If there are any lesions, now this can include those fibroids, you're going to describe those. Try to find the location or the location of the epicenter if you can. I'll admit endometrial carcinomas can be difficult to do that with, but you try your best. You're also going to give a 3-dimensional measurement here. So something to note is you're likely going to have to get 3D measurement and then extend that measurement when you look at the invasion. So these exophytic masses kind of give you a nice little 3-dimensional structure initially, but it's likely you're going to have an increase in one of the dimensions when you serially section and see if there's invasion. So we'll talk about that too more in lab. Then as you serially section, your typical measurements are going to be your endometrial thickness and your myometrial thickness. So we talked about the need for having myometrial thickness. You also measure the depth of invasion, so we can get that 50% number if possible, as well as number of lesions. Now this isn't predominantly for fibroids. Sometimes you'll see a lot of intramural fibroids when you're cutting, so you give an estimate of those, as well as a size range. Typically, endometrial carcinomas tend to be continuous, so you don't have multiple lesions there. Something of note also is if you did describe nodules or any sort of subserosal bulging on the outer surface, this is a good opportunity to correlate those. So if you see a mass within the myometrium, it looks kind of like what one of the previously described nodules that you mentioned on the outer surface. I usually just correlate that when I'm talking about the mass there. I'll say I have a 4.2 centimeter fibroid that corresponds to the previously described anterior serosal nodule. And then tubes and ovaries, we'll talk about that later on how to prosect those. So that is your uterus, kind of your basic. Now let's take a look at the benign uterus. So the benign uterus is very basic. Let's say you get a prolapse uterus where you just open it, nothing of note, everything looks pretty normal. What do you take for sections? And let's assume in this case that you don't have tubes and ovaries because they were kept in there. So what we'll do is, once you've done all that previous work, which is going to be describing, measuring, doing your classic Path A stuff, now what you'll do is for the sections, you just want to take essentially 3 from each side. So everything's going to be an anterior side and a posterior side. So you want to get an anterior cervix or a 12 o'clock cervix and a posterior cervix or 6 o'clock. You're also going to need sections of the uterus. Now, if there was a subtotal, then obviously you can disregard your cervical sections, but you'll still want to get your sections of the uterus here. So here, from both the anterior and posterior sides, you want a lower uterine segment, and that's going to be near the junction of your inner os or internal os for the cervix, where it becomes the endocervical canal, and then a full thickness uterine wall. And so that's something that probably about halfway up the uterine body, I'll take that section. Ideally, try to get something that sort of demonstrates the average myometrial thickness. Now, if there's a little bit of pathology, just a smidge, and it's not really that bad of a pathology like in fibroids, the only other difference is we now have to take our typical pathology section. So if it's a fibroid, classically, you're going to do your 1 section per cm. Honestly, these tumors can be so common that a lot of places might even have their own sort of sub-protocol. So they might just want 1 section maximum of each fibroid just to document it, unless it's over a certain size. I had a place that did that. And sometimes it's not necessary, especially if there's a lot of little fibroids. It might not always be necessary to get a section of each one, but do your due diligence and try. And that should be your first go-to, is if you see 6 nodules, try to get at least 6 sections or 1 section from each nodule. Again, this could vary from your place, but as long as you're doing your due diligence and you go in there and saying, all right, 4 centimeter fibroid, I'll take 4 sections of it, there you go. And let the pathologist come and say, oh, that was too many. But that's on them, not you. Any areas that look interesting, so sometimes you can get fibroids with calcifications. I wouldn't say you necessarily have to decalcify a fibroid, but you can get some of the adjacent tissue to the calcifications. In areas of hemorrhage, cystic degeneration, or necrosis, anything like that, that should be red flags for your sectioning. Okay, now if you get a hysterectomy that happens to have a history of endometrial carcinoma or possible concerns for endometrial carcinoma, here's the submission you're going to look for that. So we're still going to do our posterior and anterior sections, so that'll include lower uterine, full thickness, and your cervix if present. Although things can get tricky now because there's a maths there, so you might have the entire posterior endometrium involved with endometrial carcinoma. So your full thickness is going to look a little unique. I do try to get those that are non-involved if possible, but sometimes it's just not possible. So don't stress out if you absolutely can't get a non-involved normal section for each side, but you can at least try. Now for the mass, you're going to do your standard protocol. So unlike fibroids, you definitely want to do 1 section per greatest cm of the mass. And like I mentioned for the intraop, if you didn't do the frozen section for this, and they didn't submit your potential greatest invasion, you're still going to look for that and submit it. So you want to make sure that you get a depth of invasion, as well as still calculate, I guess I shouldn't say calculate, but determine if you've invaded past that 50% mark. So you want to use that previously measured myometrial thickness and your depth of invasion, and then you can kind of say, like, this invades X number of centimeters out of Y number of centimeters of myometrium. If there is perimetrium present, so you're going to submit the entire perimetrium. So remember, that is important for staging. It's not part of your standard total hysterectomies. This is usually a radical hysterectomy. Now, sometimes you'll get something labeled as a total, and if you kind of look at it just the right way, there's a little bit of perimetrial tissue present. Feel free to ask the pathologist if they want it, if it's kind of scant amounts. This is usually more important for cervical carcinomas, so definitely I would try to at least get something for cervical cancer. Uterine cancers, it's kind of going to be up to your place if they want to try to scrape together a little bit of perimetrium from each side. If it is listed as a radical hysterectomy, though, then make sure you're submitting perimetrium, even if it's just like a small little bit of perimetrial tissue that you scrape off the side of the cervical neck. Now, if you do have any fibroids present, you would also submit those, and this is where it's helpful if the site has their own sort of fibroid doctrine, because if you're submitting all this stuff for your tumor, and then there also happens to be 6 to 8 fibroids that you have to deal with, that can be a lot of cassettes. So if they all look relatively homogeneous, sometimes you can get away with a couple sections in a cassette or something along that lines. But again, your default should be 6 different tumors. You're going to submit to 6 different sections of each of them, or at least cassettes. So as long as that's your default, that's fine, and then you can kind of work out the details after that. It's fairly common that you'll see tubes and ovaries removed with these specimens. A lot of times they tend to be common sites of metastasis, so either ovarian tumors metastasizing to the uterus or uterine tumors metastasizing to the fallopian tube slash ovary. So a lot of places will actually have you submit the tubes and ovaries entirely just because there's likely an increase in carcinoma risk for those. This is where what we'll talk about is like the CFIM protocol for fallopian tubes. But even then, you're definitely going to want to make sure you submit everything, no matter how big well, if the ovary is super, super big and not quite like, if it's kind of a large cyst, you might want to work with the pathologist to see if there's anything else you can do, but your default, again, should be submitting that entirely. Now, the other thing to talk about here is endometrial hyperplasia. So if this is a history of endometrial hyperplasia, this is what we're going to do is known as sort of trimming or mowing the lawn. So you can do your standard sections, your anterior posterior cervix, anterior posterior lower uterine segments in full thickness. But then afterwards, you're going to want to submit the entire endometrium. So after you serially section this, and I'll move on to the next slide. So after you serially section this, let's look at this cross section here. Oh, this is all tumor. But basically, upon serially sectioning, you're going to have a endometrial layer and a myometrial layer, and you'll just cut off the endometrial layer and submit that sequentially. Really, I do my best to try to wrap it up and keep it somewhat organized. It's not always easy to do, but again, the important thing is making sure you're submitting it entirely, because this is a potential risk for cancer, so they have to look for invasion to rule out any early stages of carcinoma. Now, if you recall, for the hysterectomy for cervical dysplasia, that's what we look for where we submit the entire cervix. So remember, hyperplasia for endometrial carcinomas, submitting the entire endometrium. Dysplasia for cervical carcinomas, submitting the entire cervical mucosa. Okay, now let's take a look at staging and just staging. So what you'll see, or may notice, and you probably noticed this for some of the content last week, is there is the PT category and there's a FIGO category. Now, for whatever reason, I don't know the entire history. I think it just happened to be a grandfathered in type of thing. The FIGO system was invented prior to the AJCC for female carcinomas. But FIGO is a European institute. I'll try my French, but I'm probably going to butcher it. It's the Federation Institute of the Gynecological and Obstetrics. I think that was close enough. But that's the FIGO stage. Now, ideally, you'll hear everything referred to in FIGO stages when you're in the clinical site, so it's a good habit to be in. Fortunately, the FIGOs correspond with the PT stages, right? So the pathological T staging. So you don't have to really differentiate what you're comfortable with. So if you're going to just call it PT1, that's still FIGO 1, you're good on, yeah. The other thing I want to point out, so normally I have a rule between A's and B's, right? This is the one time I emphasize a distinction between A and B. If you'll notice, we talked about the depth of invasion being 50% and how important it was to note that. You're going to make sure that if it is below or beyond 50%, you document that during your intraoperative consultation, because that's going to change whether or not the patient gets additional surgery. So now it has a practical element in what we do, or what happens to the patient. However, it really only changes the stage from a PT1A to a PT1B. So it's not really upstaging per se, that 50% invasion. It's really just a dictation of how to proceed surgically. So if I asked you, why is it important to document the depth of invasion in the tumor? Technically, it's not because it upstages the patient, right? Technically, it's because it's going to indicate whether or not there is a likelihood for spreading the cancer and how much further treatment is needed. Other than that, your staging is going to be associated with just general involvement. So look for the local structures, whether you're invading into the cervix or vaginal canal, and even to a great extent the perimetrium. And then when we talk about the pelvic exonerations, the T4s, that's when you start invading into the bladder and or bowel mucosa. So that's what we see here. So here's a uterine tumor. This is typically with cervical carcinomas, just because they don't have that serosal covering, and they tend to be pretty close proximity to these other mucosas. But we have portions of our rectum here, we have the bladder, and then the uterus in between. So in very advanced cases of cervical cancer and sometimes vaginal cancer, you'll get these excisions. Now they look complicated and scary. And the first time you get one, you might be somewhat overwhelmed. But ultimately, it's actually somewhat easier. These tend to be quite simple to gross because the tumor is so advanced, right? At this point, if you can visualize that it's actually involving the bladder or the bowel mucosa, that it's automatically a stage 504. Now, what you're going to want to make sure you do is when you get this specimen, document what you have. So what components are present? That means, okay, I've got the rectum, maybe anus with anus mucosa, cervix, if you can see it with uterine body, vaginal canal, maybe vulvar skin, bladder with urethra and ureters. Those are things you're going to want to look for and document, because the main goal here is verify the extent of the tumor. So really this one section here, or even this one down here showing, let's see, I'll do my pen. So if I took we'll use yellow. If I took a section here, right, that pretty much shows, yep, that's likely going to be a stage 504. Okay, so that's one part of grossing. The other part of grossing is making sure that the tumor is completely removed. Now, to be honest, these excisions are usually more palliative because the tumor is so advanced, it's likely already metastasized. But still, we want to make sure that what was removed is entirely complete as far as the tumor goes. So we've documented the staging and diagnosis, which we got here through this section. Then after that, you're going to want to look for your margins. And the margins are just going to be dependent on what structures you have. So we talked about like the vaginal mucosa margin or with the vulva, how you can have the skin margin attached. Same with when you talk about the GI tract, you'll go into the margins there, and then eventually the margins of the bladder. But here I've listed them out for you and what you need to be mindful of. So you got proximal distal colon, vaginal/vulvar margins, as well as ureter and urethra margins. And then you can't forget that surrounding all this is all going to be soft tissue, so you have that radial margin to be mindful of. And the other thing to consider is how is or is there skin present, right? Because it could be a mucosal margin down here, or it could be skin margin. And so it's worth being mindful of what's present, because if I tell you there's vulva and anal skin attached, and then you say there's a vaginal mucosa margin, that would be incorrect, because there's technically no vaginal mucosa margin if there's a vulva attached, if that makes sense. So I don't expect you to prosect one of these or have to write that, but when you are looking over this or assessing these, I want you to be able to identify your margins, okay, and know what margins you would submit for these and which sections are most important. So that'll be the takeaway for that pelvic examination. Next up, let's talk about the uterine tubes or fallopian tubes or the oviducts, the Mullerian ducts, whatever you choose to call them. Let's talk about them. Don't blink or you'll miss this section. So first, this is a little benign pathology that's really more of an incidental finding than anything. But you'll likely see paratubral cysts when grossing fallopian tubes. And they look like this little cyst that's kind of coming off there. Typically unilocular, very small, less than half a centimeter. And they're just going to have serous fluid inside. Word of caution is when you are seriously sectioning, just I would poke these rather than cut them, because they'll be under a lot of pressure and could potentially splash. In fact, ovarian tumors we'll talk about also could potentially splash in your face. So wear eye protection or be diligent when opening these cysts. But again, incidental findings, you can describe them and then submit them with your fallopian tube sections. So fallopian tubes might also be received as a result of infection. So we talked about pelvic inflammatory disease last week, which is a disease typically starting with a lower reproductive tract infection, making its way up to the upper reproductive tract, seen with things like gonorrhea or trichomoniasis. This can result in two types of manifestations. You can either get a pus-filled fallopian tube or actually pus-filled ovary or fallopian tube. or you can get a hydrosalpinx, which is going to be a water-filled one. So if these infections are allowed to persist, they can uh, really be problematic. And you can see here these kind of advanced stage salpingitis. They're starting to involve the ovary as well. So it might be difficult to even parse out the tube and ovary in some of these advanced cases, which you can kind of see here. It's very difficult to tell if there's tubes and ovary present or not. There's also hematosalpinx, and this is typically seen with an ectopic pregnancy. So ectopic pregnancies can occur if the zygote implants itself. So usually implant or fertilization will include or happen at the ampulla of the fallopian tube. And ideally, the zygote or the fertilized products will make their way into the endometrial lining. That might not always be the case, and you might get implantation in the fallopian tube. This is commonly, or I shouldn't say common, this is more common in individuals who have endometriosis or any sort of like endometrial tissue there. But typically what you'll see is this tumor will, or the child will start growing, but it doesn't really have the proper placement and location. So eventually it's just going to be obstructive, and this will cause kind of a dilation of blood. So ultimately, the patient will experience a lot of pain, and this will have to be removed. You'll talk about ectopic pregnancies and fetal tissue prosections when you get to the pediatrics in the fourth quarter. But basically, we want to make sure that there is a viable tissue or viable fetus present. So you'd be looking for choriotic villi and fetal tissue in a case like this, just to make sure that was the reason for the resection. As far as tumors or carcinomas go, there's really two that we'll work with. Adenomatoid tumors, which are typically benign. They're going to be these little nodular growths of the mesosalpinx. I've not really ever seen these, so if you ever kind of see these specimens, they'll probably be kind of cool. There's also the malignant lesion or primary adenocarcinoma. Now, what's interesting of this is because of the similarity in origins of the tissue, so we have that Mullerian duct tissue, and you remember that the Mullerian tubes were fusing during embryo to create the uterus, the vaginal canal, cervix, and all that. So there's a lot of similarity in originating tissue types here. And as a result, there is some thought that some ovarian carcinomas that we get, which are also adenocarcinomas, are really just fallopian tube primaries that metastasize or just locally invaded into the ovary. These also, because if you recall from our anatomy, the pelvic cavity, or particularly the superior portion of the uterus with its tube and ovaries, are kind of hanging somewhat free in the lower abdominal cavity. And our omentum, which is our nice little like apron of fat hanging on the inside of the abdominal cavity, is really just nice and close to that. So it's not uncommon for these, and same with ovarian tumors, to metastasize to these omentum or these pelvic cavity tissue areas. And as a result, these can be, at any sign of metastasis that can happen, the metastasis can happen quickly. And fallopian tubes are more prone to this because they're not as contained. They don't have the capsule that ovarian tumors do. So as you can see, they're quite aggressive, and 40% of patients will die within 5 years. So ideally, or I should say not an ideal carcinoma to get. Now, if you don't have a carcinoma, or you don't see anything worth noting, or you have an associated carcinoma such as ovarian tumor or uterine tumor, you'll hear this protocol called CFIM. So it's really just a fancy way of saying do your job. And what it stands for is sectioning and extensively examining the fimbriated end of the fallopian tube. So we do that by looking at the fimbriated end, and what we'll do is we'll truncate that off. So if you recall, like the cervical portion of the radical hysterectomy for cervical cancer, you just sort of cut off the cervix when you're ready. Here we're going to cut off a fimbriae. So you see our fallopian tubes up here with the fimbriae detached. So that's going to be step one. From there, we're going to serially section the tubular component, just like you normally would. But then you're going to do a hard 90-degree turn, and then you're going to cut, longitudinally cut your fimbriated end. So you can see over here in the nice little APA drawing, they got the nice, easy to see fimbriated end nicely cut. It'll almost never look that cool and clean. But that's the goal, and that'll help visualize, for the pathologist to visualize more of the fimbriae of the fallopian tube on the cross section. And then you'll have your typical fallopian tube segments submitted on end. So the reason for this is, like we said, there's usually a lot of metastasis of these common origin type cancers, these Müllerian cancers, which can be anything from ovarian to uterine, fallopian tube. They can kind of be insidious and show up where you least suspect them. So doing this sort of thorough investigation of the fimbriae of the fallopian tubes and the fallopian tubes themselves, we can just identify whether or not there's any actual carcinoma present. So this is going to be a common procedure you do. Now, unfortunately, there are some fallopian tubes that do get rather long. So you can be submitting a dozen cassettes of just fallopian tube cross sections, but it is what it is. In those cases, you can always ask a pathologist, but again, err on the side of over submission / caution when you can. There's also a case where you might see a lot of these specimens for prophylactic submission. So BRCA positive women, and this is a sort of cancer-related gene, if it's present in women, they have an increased risk for breast cancer as well as ovarian and potentially fallopian tube cancer. So you'll talk about BRCA when you get into the breast lecture in a few weeks. But in terms of ovarian cancer, we have an over 50% increased risk of carcinoma and even a mild increase of fallopian tube carcinoma. So that being said, if a woman wants to just preemptively remove both tubes and ovaries, look at that bilateral salpingo oophorectomy, you're going to make sure to do due diligence because of that likely increased risk to do the CFIM protocol, basically submitting everything. So again, if you see it in the history is prophylactic, make sure it's not for BRCA, because if it's prophylactic and just a normal routine removal, maybe for like a torsion or something like that, you can just do representative sections. But BRCA cases, you're going to want to make sure you're doing a very thorough examination and treat them very similar to your cancer cases, we'll say. Okay, and then for staging, ovarian and fallopian tube carcinomas are staged very similarly. So you can refer back to this chart for the ovarian tumors as well. But these will also use the FIGO staging. So again, it's good to get in the habit when dealing with any gynecological cases to refer to them as FIGO 1, 2, or 3. The biggest things to consider are laterality. So whether it's found on one side versus both sides, so you might have to refer to the history or see what you get. You're also, particularly for the ovary, we're going to look for capsule integrity and if it's locally invasive. One thing to note is there's no 504, right? So we stop at T3, and local metastasis is actually part of that. So it's kind of an unusual staging criteria for fallopian tubes and ovaries because they are kind of unusual tumors, especially ovarian tumors, which we'll talk about shortly, like right now. So let's take a look at ovarian pathologies, and of course we'll start with the benign first.
So let's go ahead and start with benign pathologies of the ovary. Specifically, we'll talk about cysts, and there's about 5 different cyst types you should be familiar with. Now, given the fact that the remainder of this presentation is the ovary, it's quite impressive that this 7-gram structure has so much going on for it in terms of pathology. But right now, let's take a look at the follicular cyst. So this is a very common thing that you'll probably see incidentally in a lot of ovaries that you prosect, and it's not likely that you'll ever get this for just a primary prosection, or I should say resection. These are usually pretty benign, unremarkable, and small cysts up to 2 centimeters wide. They could theoretically be removed in and of themselves if need be, but likely they'll just be attached to the ovary. And these result from a ruptured follicle that gets entrapped, so that serous fluid will get entrapped when that capsule ruptures and spits out the ovum. Sometimes it doesn't quite seal completely, and what you get is a cyst. Since follicles are being ejected monthly, it's not uncommon that these happen, and multiples can happen in the course of a lifetime. So something to be mindful of, and like the paratubral cysts in the fallopian tube, just be mindful when cutting an ovary that you don't accidentally hit one of these and get it to splash in your eye. It's not like I'm speaking from practical experience, or am I? Now, if we can get a remnant follicle, we can also get a remnant corpus luteum. So a corpus luteal cyst is just a persistent corpus luteal structure. Now, if you recall, the corpus luteum was the primary sort of stand-in endocrine type structure, like for pre-pregnancy. This is going to help produce the progesterone to keep the uterine lining going until the placenta can essentially take over. So what you'll see in these cases is basically that nice curvilinear yellow corpus luteal, I don't want to call it a capsule, the outer ring, I guess the cyst capsule here. I guess I wrote boundaries. Boundaries is good. So this yellow boundary, which is sort of that outer layer, and which we'll talk about more in structure and function, this is where your granulosa cells are going to house, and they produce a lot of those androgens, which are lipids. So that gives you that yellow color here. And these can be filled with either serous fluid, depending on how they're collected, or potentially even hemorrhagic material. So you really just want to describe what you have and typically submit these entirely. Now, these could also be incidental findings. Again, they're small cysts, likely nothing they might show up on ultrasounds, but it's nothing that will warrant a resection for them. Now, on the other hand, thecal lutein cysts, if found, will need to be excised. So these are often a result of gonadotropin stimulation, and they can be multiple cysts or bilateral. Here you see kind of a multiple cystic structure. And the thecal lutein is part of your follicular structure, so it's not the granulosa cells, which we'll talk about tumors of those, but these are cysts that can form from the supporting structures. So sometimes these can be associated with hydroactiform moles, which we'll talk about in pediatrics, and choriocarcinoma, which is kind of a placental associated carcinoma, but also you can see it with germ cell tumors. Back to the incidental findings, unless they are, again, very large, is the endometrial cyst, or what's often referred to as a chocolate cyst. So looking on the cut surface, it kind of looks like a melted Hershey Kiss got trapped into the cyst here. Now, what this is actually, what actually is happening is there's endometrial tissue usually embedded in the ovary somewhere. So that'd be our endometriosis. And that endometrial tissue will still respond to our progesterone and estrogen, our ovarian cycle hormones, things like that. So it's producing a lot of this material, we'll say. And what you get is kind of this chocolatey, sort of thick, like brown, black material that is just endometriosis material, endometrial excretions. So these can be also malignant or signs of malignancy if they're thickened walls. So you'll find out that when we look at cysts, we're really focused on the cyst wall. So make sure you're paying attention to those if it looks unusual. Right here, these cyst walls look pretty uniform. You could argue this is thick, but if you see there's like multiple cysts, so the wall lining is actually pretty consistent throughout. So you don't want these to be held on too long. So if they are found and are continuing to grow, they will be removed in that case, just because they can continue to grow as that material keeps kind of secreting into the cyst opening and it continues to expand. And then finally, we'll talk about the polycystic ovarian syndrome, or PCOS. This was previously known as Stein-Leventhal syndrome, but this is a complex endocrine disorder. So it'll manifest with hyperandrogenism, which means that a woman might show male characteristics, and a common one is growing facial hair. So people who have polycystic ovarian disease, or PCOS, might actually have beards or mustaches. You'll have abnormal menstruation or lack of menstruation, polycystic ovaries, which you can see here. This is going to involve or impact ovulation, so you might lose ovulation on the ovary depending on the cyst. If there's really no structure to the cortex medulla complex, you might not be able to properly release follicles, and that ultimately releases or realizes into decreased fertility here. So both ovaries will typically be involved because this is an endocrine disorder. And usually you're at risk with diabetes and obesity, kind of the similar ones we saw with our other estrogen-related conditions. And these are also associated with an increased risk of ovarian carcinoma, adenocarcinoma specifically. So again, this is something that you might just be inherited, or you might just inherit or have a complex interaction of endocrine factors leading to it. Okay, so here's a list of all the ovarian tumors we'll talk about. Like I said, the ovary's got a lot going on for it, so it's quite impressive. There's a lot of similarities, though, and honestly, when we get to the grossing, unlike the uterus, where there's a lot of different paths to take, these are pretty straightforward, and ovaries are kind of fun to gross, in my opinion. So let's start with the epithelial tumors. So when we talk about epithelium, so that's basically that glandular tissue, that stuff that's going to be making up kind of the prominent portion of our capsule and gland secretion, our serous glands or mucinous glands. So the primary ones are serous or mucinous cystadenomas. Now both of these, whether it's serous or mucinous, will present in either a benign, borderline, or a malignant condition. So these are adenocarcinomas. Again, both serous and mucinous. I'll talk about mucinous in a little bit, so I'll just stick with serous. So these are adenocarcinomas. And our serous typically presents, if it's just an adenoma, you have a unilocular cyst with smooth linings. So if you kind of look at this here, it kind of looks like maybe a shower cap or something, or maybe a water balloon. But it doesn't look problematic, right? If you saw this kind of laying there, you might just think it's like a shower cap, I guess. I don't know. But this is indicative of like a benign tumor, right? There's really nothing scary about it if you looked at that. I mean, the fact that it's growing in there, and this is a fairly large cystic structure, and some of these can grow quite large, to be honest. But they're filled with serous fluid. It's usually clear, and these tend to be unilateral, so you just have one. However, as you kind of move along the spectrum of these cystadenomas, sometimes they might have papillary projections inside, which we refer to as papillary excrescences. And this is where we start worrying about borderline tumors. Histologically, we're going to have this glandular looking appearance, again, these serous glands. So depending on the papillary projections or just whether it looks like a cystic structure, the epithelial lining will be very similar to the lining of the fallopian tubes. Again, it's well differentiated. This is a low-grade tumor, essentially. We can consider it benign. But these serous cystadenomas are predominantly all these fluid-filled, one single unilocular cyst. So those papillary projections, however, can change things. Now, if you get these and you start seeing something like this, where there's little papillary excrescences throughout the inner lining of the cyst, or maybe even on the external surface of the capsule, that's when you want to start being more diligent. Not that you weren't being diligent before, but now you can be extra diligent. So these will likely harbor malignant cells, or potentially give a greater increased risk for malignancy the more papillary projections there are. So when you get this specimen, and it's not uncommon to receive these ovarian cysts for frozen section, in the last specimen, you can just kind of target any section of wall. But here you're going to want to focus your sectioning for frozen section and submission on any of these papillary projections. Histologically, the tumor will also look kind of like complex papillary patterns. But in a borderline lesion, there should be no invasion. It's called borderline because there's atypical cells and it contains the potential for invasion. And the argument being, well, you're only really looking at a small glimpse of it, especially if you're doing an intraoperative consultation. So this is considered sort of, for purposes of staging or purposes of submission, malignant. So if you do a frozen section, you see some papillary excrescences, and there is some atypia, and they call it borderline, they're going to treat it as potentially malignant because there could somewhere be, in any of these papillary projections, actually invasion into the basement membrane. So when looking for lesions or tumors, or I guess when I'm looking for carcinomas in these cystadenomas, always look for your papillary excrescences. In the extreme version, the cystadenoma can evolve into a cystadenocarcinoma or serous adenocarcinoma. Sometimes they're referred to, the cyst being implied. So this is the most common malignant tumor of the ovary. So typically you'll see these quite often. They're going to have a diffuse areas of papillary projections, hemorrhage, necrosis. They're going to have areas of thickened walls or maybe solid areas, hemorrhagic cysts, things like that. They just don't look really pleasant. So here on this kind of cross section, you see a multiloculated cut surface. You see some areas of necrosis and hemorrhaging, some solid areas here too. Really a lot going on. Variations in cell or cyst wall thickness here. So you have really thin ones here, and then you got some thick walls over here. So this is not looking pretty. So that should kind of be the first clue, like, oh, yep, this is likely a carcinoma. So you shouldn't have to ever worry about, oh, is this borderline versus malignant? That's not anything that you'll ever have to worry about, because you should be doing your normal due diligence of sectioning areas that are concerning. Histologically, you'll see kind of just chaotic glandular presentations, mitotic bodies, pleomorphisms, and even some multi-enucleation on some of those cells. Also, a sort of pathognomonic for cyst adenocarcinomas are these sort of reactive areas of calcifications, these little circles of calcifications here. It's kind of felt like these are dystropic calcifications into response to the tumor, but they're referred to as psammoma bodies. So if you see these in here with a kind of your glandular tissue in complex and atypical pattern, you should be thinking cyst adenocarcinoma. Now, the mucinous cyst adenoma, so this is going to do a similar thing, right? We're going from benign, borderline to malignant. And again, borderline is going to be that sort of in between where you can't quite rule out malignancy. But the same rules apply here. The only real difference is these will have mucinous fluid contents in the cyst. And sometimes even benign ones tend to be a little more multiloculated, whereas the serous was usually just one single cyst. Mucinous cyst adenomas tend to be multiloculated, having multiple small cysts on the cut surface. But again, your same rules apply. Look at how thin the wall is kind of universally around, and look at how smooth the lining of the cysts are as well. With that being said, we're going to also look for those papillary excrescences in these types of tumors. That'll be your sort of target for sectioning, because that's where likely any sort of malignancy or foci of malignancy can hide out. The adenocarcinoma version, or the cyst adenocarcinoma version, looks much angrier. So again, multiloculated cut surface, the variation in solid and cystic areas, as well as the variations in cell wall, cyst wall thickness, diffuse hemorrhage and necrosis as well. And again, you're going to have some of that mucinous deposition in the cyst. So a lot of times, if there's just a little bit of mucin, you'll kind of have a nice little sort of pseudo-serous mucinous fibrille. But if it's got a good chunk of mucinous cells producing mucin, when you open these up, they've got a kind of a, I mean, if I'm being honest, it feels like just a big old pile of snot. I do find that when you stick these in formalin, it helps sort of break up the mucinous fluid. It makes it a little bit easier to work with. Otherwise, these get quite sticky, and your scalpel/blade can take some wear and tear. Now, what we're looking at with these is overall, these tumors are quite rare. So typically, the common benign tumor for ovary tumors are mucinous cyst adenomas, and the more common malignant tumor is this serous cyst adenocarcinoma. But these mucinous cyst adenocarcinomas, although rare, are very problematic. So if they are contained, great, they have a nice high survival rate, but any sort of distant metastasis or rupturing can quickly spread, and we'll talk about this pseudomyxoma peritonei shortly, especially how chemo-resistant these can be, or treatment-resistant. When actually acquired, metastasis usually is often fatal. Okay, so we talked about endometrioid-type tumors in the uterus. You can also get endometrioid-type tumors of the ovary. And as you can guess, this is likely because they look like endometrial tissue. These are partially associated with endometriosis, and if endometriosis is present, it actually can lead to an early development of this tumor. Otherwise, these typically are later in life tumors. They can be unilateral or bilateral, but are kind of a flip of the coin of whether they're bilateral, so it's not uncommon to see bilateral endometrioid tumors. And there's also an association with endometrial carcinoma of the uterus. Now, this makes sense if we talked about kind of how there's a constant sort of exchange or likelihood of metastasis from one Mullerian structure to another. So uterine tumors can make their way up to the fallopian tube and ovary, and ovarian tumors can go down to the uterus as well. So these endometrioid tumors can do just that. But they can be solid/cystic tumors, may contain blood or mucin. They look predominantly solid, so they don't have that cystic look that we saw with the serous or mucinous. But histologically, you're going to get a very classic look of endometrial glands. So it should just look like an endometrial atypia with tubular glands present. Clear cell carcinomas are another type of epithelial tumor, are very rare, but they are usually borderline or benign, especially if they're contained. Now, if they do spread beyond the ovary, the prognosis becomes significantly worse. But the nice thing about ovarian tumors is a lot of times that thick capsule keeps a lot of these tumors contained for a while. So you'll see that this is why they can get so big, especially those cystic structures, is because they're just really held in closely with that capsule. But what you'll see is solid or cystic areas, and they typically have papillary projections. But what they get their name from is these clear cells histologically. So they get these hypersecretory endometrioid type cells, but the cytoplasm is clear. So realistically, you probably wouldn't know it's a clear cell carcinoma grossly. But if you could look at the histology, especially if knowing that it's a rare tumor, that'd be kind of a cool one to see. And then finally, of the epithelial tumors is Brenner tumor, or a transitional cell tumor. So transitional cells are typically found in the urinary tract, but you can get these nests of what look like transitional type cells within the stroma here, this ovarian stroma. And these nests kind of are indicative of Brenner tumors. So these are usually unilateral tumors, but as you can see, the size can be quite variable. That's quite common with ovarian tumors in general, but usually it's the cystic ones that are the most varied in size. The solid ones tend to kind of be a little more distinct. But we'll talk about fibromas in a little bit, but this has, like, if you kind of were to describe this, it has a sort of whorled look to it, right? Which is very similar to those fibroids we talked about, or the leiomyomas. Whereas histologically, you're going to look for those nests of transitional epithelium, kind of just contained within that stroma. Okay, let's talk about germ cell tumors. So these are tumors that are actually going to be very similar to tumors found in the male reproductive tract. So the first is dysgerminoma. So this is a analog to the seminomas found in males. Now, you'll talk about this in male repro with lectures coming up. So we'll give a basics for the dysgerminomas. These tend to be a little more malignant than seminomas. Seminomas are actually quite treatable in males. They're a testicular tumor. But dysgerminomas tend to be a little more malignant when found. They usually have a lobulated fleshy appearance. You can kind of see on the cut surface here. The external surface was also kind of nodular, lobulated. And they usually occur earlier in life. Much like those clear cell tumors, you got this sort of vacated cytoplasm here. But overall, these are going to be of germ cell origin. Next is teratomas. So the main one is the mature teratoma, which is referred to as a dermoid cyst usually. The reason it's called a dermoid cyst is because the cyst lining kind of has it looks like skin epithelium. So it's got this like little porous thing, looks like portions of skin. Can be kind of weird. But a teratoma is going to be 2 or 3 embryonic layers. So the embryonic layers are the ectoderm, mesoderm, and endoderm. And each of those are going to have like their corresponding developmental components. So you want to have at least 2 of those present. So if that skin-looking component is present, that's typically the ectodermal component. And then you can have like muscle or bony type material, which is typically your mesoderm. And you can get other varied structures as well. These tend to be filled with a sebaceous material, which is usually quite disgusting, smells awful, and it gets everywhere. So they're initially fun to gross, but you'll get tired of them quite quickly because they're fairly common and they're pain to clean up with actually. You can get other versions of teratomas, which include an immature and a monodermal type. So if it's a mature teratoma, that means the cells have kind of gone to their final destination. So if you see in the image here, we have teeth. So the tooth cells became teeth and the skin cells became skin, and if there's bone, they became bone cells. If there's other things in there that there and stuff, they all kind of did what they were supposed to do. In the immature teratoma, what you'll actually see is kind of, this looks like embryological tissue, sort of just no definitive form. And these tend to be more malignant than your actual teratoma. Teratomas should not be, they're classically benign and non-invasive, but immature teratomas, because they're really just like low or high grade tumors, if you think about it, because everything's poorly differentiated, they tend to be more invasive. And then monodermals are associated with a very specific tissue type. So instead of having 2 to 3 embryonic germ layers, this tends to be just a one germ layer or one cell type, and the most common one is thyroid. So here's an example of a monodermal teratoma, which is called struma ovariae. This is the most common one we see in the ovary, and this is just thyroid tissue. So if you see the histology here, it looks very similar to the thyroid histology with those follicles filled with collagen. Here you got what looks like, if you didn't know better, it looks like it could be a goiter from a thyroid, but it's actually an ovarian tissue. So these are essentially mature teratomas that are fully developed, so you're not really worried about invasion. However, I didn't get the case, but another PA I worked with actually had a case where there was a struma ovariae, so it's basically a thyroid tissue in the ovary, but within that thyroid tissue, there was thyroid carcinoma. So now it gets all kinds of weird. Like, is that like technically an ovarian tumor? Is it a thyroid tumor? I think they had to gross it as like a thyroid tumor initially. That was a few years ago. I'm starting to forget. But these have this nice little collagenous look with multicystic appearance. So think, again, goiter from the thyroid. So a yolk sac tumor, these are tumors of the yolk sac cells, or cells of yolk sac origin. So this is the second most common malignant tumor of the germ cell origin, the first being the dysgerminoma. And this typically occurs early in life, that second decade. They appear like your standard kind of multicystic hemorrhagic tumor. But on histology, what we're looking for are these Shaler-Duval bodies, which are basically going to be a central blood vessel, which you can kind of see here. Oops, that's a bad circling. Surrounded by tumor cells. So that's kind of a classic appearance. Again, we mostly deal with the gross. So if you're looking for kind of a smaller mass with this yellow to gray cystic cut surface, granted, that could be just about any germ cell tumor, but that would get you thinking yolk sac tumor, hopefully, especially if it's an early patient, early in their like 20s, 30s. Finally, we have choriocarcinomas. These are actually placental tumors, but they can be found in testes or ovaries as well. They usually have a mixed, and a lot of times when we have germ cell tumors, especially in males, they kind of are variations or mixed with other germ cell tumors. You get a little bit of yolk sac, a little bit of choriocarcinoma, maybe some teratoma elements, or dysgerminomas. So these are very aggressive tumors. They tend to be small, aggressive, and lethal. They are very unresponsive to treatment. So if found, they can be very problematic. One way to discover these is actually using a pregnancy test. So they do exhibit high levels of HCG, human chorionic gonadotropin, which is the same stuff we would identify in the placental implantation. So technically, if you get a pregnancy test, you could also, or a positive pregnancy test could also be a choriocarcinoma, which could save your life. So that's something to consider. All right, sex cord metastatic tumors are the last group. Sex cord tumors are really just the supportive cells of the gonads, and then metastatic tumors will just be the tumors that make their way to the ovary. So first up for the sex cord tumors are thecomas, fibromas, and then fibrothecomas. So these are going to be of stromal tumors with either fibroblast origin, which would be the fibromas, or spindle cells, which are thecomas. But more often than not, they're going to be a mix of both of those. You might see fibromas occur kind of pure. They look like leiomyomata or Brenner tumors, depending on how you want to make the association. But they have a nice little whorled cut surface. They tend to be very solid and firm. But those are all fibrous tissue, so it makes sense. Thecoma is getting those kind of pure without any fibrotic elements is rare. So you usually see them as fibrothecomas, but a thecoma is going to have a little bit of like yellowish tint to it because these thecomas are associated with the outer portion of your follicles, those cecal cells, which help promote estrogen production. So that estrogen is what kind of shows up as that fatty yellow. They could have calcifications, but they're still typically going to be a solid mass. They also, this one looks like it's got a little bit of that fibrous, you can kind of see here, oops. These look like fibrous components. So I believe this is a fibrothecoma. Again, that's classically how you see these present. Oh yeah, I have it labeled here. Fibrothecoma is on the bottom. So there's part of your fibrotic elements. Again, you can sort of make out, maybe if you squint, you can see that whorled appearance of the fibroblasts. So not only can the thecal cells of the follicle be a tumor, so can granulosa cells. So if we have a rogue granulosa cell that decides to make its own little mass, and you can see they can get somewhat large. This one's on the smaller side, but they can get up to 12 centimeters. They have a glistening, kind of grayish cut surface, and they usually have a little bit of yellow. The yellow is associated with functional granulosa cells. So the granulosa cells, you'll learn, is part of the estrogen production. So if there's producing estrogen, we should see the kind of lipid-ish look of that yellow characteristic. Histologically, what you look for is these Cal-Exner bodies. So these are just little like punched out eosinophilic areas within the tumor that sort of resemble follicles of the ovary. So in the cortex, you'll see these kind of follicular type structures with granulosa cells surrounding them, and those are your follicles. But you kind of get these mimicky ones in the granulosa cell tumors. It's like trying to go back to its old ways, I guess. So you'd look for those. So I won't test you on it specifically, but that'll probably help you with pathology. It's just thinking, oh, Cal-Exner bodies, granulosa cell tumors. Now, the other problem with these tumors is, and this is very common to any sort of endocrine tumor, is when you're functional, when the tumor is functional and essentially low grade, the cells are doing what they're supposed to do, that means we get a lot of increase in that particular hormone. And for granulosa cells, that means more estrogen. So this may have clinical relevance because we've kind of talked about how estrogen levels play a role in some of the pathologies. Now, if we happen to get juvenile version of these tumors, they're more common in older women, especially postmenopausal women. But these juvenile versions can actually cause early onset of puberty because of that extra estrogen. Breast carcinomas tend to be responsive to estrogen levels, as well as endometrial carcinoma and hyperplasia, which we talked about. So even if the tumor itself is relatively benign, some of the downstream effects could be problematic. So the final sex cord tumor we'll talk about is Sertoli-Leydig cell tumors. Now, these typically are unilateral tumors that will kind of look like granulosa cell tumors, but we haven't really talked about this since you haven't had male reproductive systems yet. Sertoli and Leydig cells are actually in the male testes, so they're testicular cells. So you'll actually see in these tumors, you'll just have these cords of Sertoli and Leydig cells making these nice little like tubular cords, essentially. So these tumors can be functional, but these tumors are going to be producing testosterone, which increase in androgen can lead to masculinization and defeminization. So this can actually block, especially in early development, or if they're kind of occurring in the early incidents in life, they can actually block sexual development and maturation. So they can be problematic because there's just hormones that shouldn't be there. And then finally, metastatic tumors. So the most common tumors we've kind of seen over and over again is these Mullerian origin tumors, the uterus, the fallopian tube, part of the peritoneum, and even the contralateral ovary tend to be common sites for these ovarian tumors to metastasize to. So it's not uncommon, and we sort of talked about the controversy of how ovarian tumors might potentially be sometimes fallopian tube primaries. And it's not uncommon that you might see some of this go, even though it's a unilateral origin tumor, it might actually metastasize to the other ovary and it becomes bilateral. So some of those tumors we saw were bilateral. So that's why a lot of times you'll see a lot of these specimens taken out as bilateral salpingo oophorectomies with your total abdominal hysterectomies. After the Mullerian tissue, what we'll see is breast and GI tumors. So GI tumors are interesting because they will actually resemble a lot of the mucinous tumors. In fact, one of the mucinous producing signet ring tumors, which is usually of gastric origin, is this, or these, we'll call them signet ring cell tumors, causes this sort of bilateral metastasis, which we refer to as Kruckenberg tumors. So these mucinous cells are going to metastasize from some sort of colon or GI tract tumor, or maybe even a breast carcinoma. You can get signet ring carcinoma of the breast as well, which is sort of a glandular mucinous tumor. They tend to find their way to the ovaries. So Kruckenberg tumor is a very specific type of metastasis where, again, it's not the ovary metastasizing elsewhere. It's usually a GI or breast tumor going to the ovaries, or both ovaries, we should say. One last thing to consider in terms of ovarian carcinoma is local metastasis. Now, I alluded to this a little bit with the fallopian tube carcinomas and the fact that they are easily exposed to the omentum. That also goes for ovarian tumors. So if you recall the image of the in situ top-down view of the uterus with tubes and ovaries, you can see how those are kind of freely suspended in the lower portion of the abdominal cavity. And if you recall from anatomy, our abdominal cavity is pretty packed, right? You got the bowel kind of all over the place. It's stacked on top of each other, and then there's the omentum. The omentum just kind of hangs down and comes in close contact with the ovary. So it's very common that you'll get omental specimens with these for tumor staging. The goal being just verify if there's tumor in it or not. If there's no tumor, you usually take a thoroughly sectioning it and then representative sections. But if you find even a little bit of tumor, that's often enough to just verify that metastasis has occurred. So the fact that these structures, the ovary and the fallopian tube, are kind of so sort of freely out there makes it more likely that they're just locally metastasized to some of the peritoneal cavity, abdominal cavity, make their way up the omentum, and cause some problems that way. So again, ideally the ovarian tumors are contained within their capsule, but if we get ruptured, that's where the problems occur. And particularly with mucinous tumors, we get what's known as the pseudomyxoma peritonei. And this is mucinous ascites and with like these epithelial glands sort of embedded throughout the abdominal cavity. So it's lovingly referred to as jelly belly, but we'll use the more accurate term of pseudomyxoma peritonei. Now, this is associated with mucinous carcinoma, so like a mucinous cyst adenocarcinoma, but only if there's rupture. And that the problem with that is when there's rupture and the spread, and even though these can kind of be washed off and treated, there can be a lot of obstruction and involvement of other structures. It used to be thought that these were associated with mucinous cyst adenocarcinomas, but more often or more lately, they're actually thinking that these are likely appendiceal tumors. So there's mucinous appendiceal tumors that are more prone to rupturing. And that can lead to this because, like I said, usually you don't get a lot of rupture with your ovarian tumors. But that's something to be mindful of, and that's kind of an advanced staged disease. So how does one go about acquiring an ovarian carcinoma? Well, for the young people, about 80% of those tumors found in young individuals between 20 and 40 are benign structures, or benign tumors, we should say. Which is great, right? You don't want to be dealing with malignancy that early in life. Most of the ovarian malignant tumors occur later in life, with that median age being 63. Again, 7 years, like we kind of see with the uterine tumor carcinomas, that's 7 years before death on average. Now, ovarian carcinomas, the more common being those cyst-serous adenocarcinomas, they have a much lower survival rate because these tumors are usually less receptive to treatment. So we have a 50% 5-year survival rate on these. Now, as far as risk factors, mucinous tumors, there's really not a lot known, and the only real, I guess we'll say, consistency between the tumors is there's been a identified KRAS mutation. But other than that, there's not like a go-to source of risk. Unlike serous tumors, we see the risks associated with mutations. You have KRAS, BRF, and TP53. Additionally, we talked about BRCA positive patients, so they can have a higher likelihood of breast cancer as well as ovarian fallopian tube carcinoma, and you might see prophylactic resections for that. Low parity shows an increased risk. So if you're not having enough kids, you might have ovarian cancer. Oral contraceptives and tubal ligations actually will reduce your risk, so there's, I guess, a way to work around that. And then there was a case not too long ago where a talcum powder was actually shown to have caused ovarian carcinoma in some women. So there's a lawsuit for that. Typically with these, the common symptoms are abdominal pain and distension. I don't know why I said dissension. They just argue with everybody. You'll see vaginal bleeding, urinary and GI tract obstruction. But what's interesting, not only does the location of the ovary make it easy to metastasize, but these cysts can kind of continually grow without too much impact on the body. So the GI tract will kind of just move around and get pushed to the side and be fine. And so it's not uncommon to see fairly large ovarian cysts removed. Some patients might just think, oh, I'm gaining some weight, or maybe even thinking they're pregnant, or they just don't think about it because it's a slow growing growth in their abdomen. And you could just be associating it with weight gain, but these can get exceptionally large prior to excision. So I think I've had one that was, I think my highest ovary was 60 grams. No, that doesn't sound right. It's pretty heavy though. So just be mindful. You can see some very big ones, cysts removed from the patients. Now, as far as prevalence, this chart is taken right out of Robbins. I won't read it to you, but it just kind of gives you the sort of breakdown of malignant tumors and how common they are to be bilateral or not. So something just worth knowing, I guess, particularly for path if you're curious of where the more common malignancies are. But as we mentioned, serous tends to be the most common malignant ovarian tumor, almost at 50% of all malignant tumors there. And typically they tend to be bilateral when you get those. So part of that being that that association between your Mullerian system, so ovary tends to metastasize to ovary or fallopian tube or uterus. So you don't have to memorize that chart, but it's kind of fun to have on hand. Okay, so let's talk about prosection. This will probably be the easiest prosection, so no need to overreact. Sorry, I had to do it. Ovaries are fun to gross, in my opinion. They are atypical from everything else in the fact that we don't really serially section, usually, unless it's a solid tumor. What we're going to do is start off with your basics. So we're going to get the three-dimensional measurements of the ovary. We'll weigh it. And then if there is a fallopian tube present, we can measure the length and diameter of that. And then we'll just describe the outer surface. So is the fallopian tube adheres to the ovary or not? Do we see anything? Is the capsule intact? Is there anything piercing through, or like papillary excrescences on the outer capsule? If there's anything of interest, like a weird defect on the capsule, you can ink it. But otherwise, we don't really ink anything on these. What's interesting to think about is most of the time when you're dealing with pathology in the body, there's a pathology within a structure, right? So let's take, for instance, lung cancer. If you have a lung tumor, you get a portion of lung with the tumor in the lung, right? And you still have margins and things to worry about. But with the ovary, when you have a tumor growing of the ovary now is the tumor, if that makes sense. So there's really no margins. There's no like relationships really to maintain, because what you're removing is the tumor. It was an ovary, now it's a tumor. So that being said, we don't really have any margins to worry about. Yeah, there's technically the fallopian tube margin, but not many people worry about that, especially if it is an ovarian tumor. Most of the fallopian tube carcinomas occur in the fimbriation end, but you can always, if your place wants, you can submit your margin of the fallopian tube. Now, once you have the specimen, if it's a cystic structure, we can open it. I usually just do one incision, usually by a sink. You don't want to splash it in front of your face, and don't get it all over your bench. So have these opened into a sink. You don't have to keep the fluid, but you have to be mindful or document what it looks like. Is it mucinous, serous, hemorrhagic? And you can just drain that all out. If it is a solid tumor, so we talked about a couple solid tumors, you can serially section those. But usually the only way to tell is to kind of make an initial cut. Or you can feel it. You give it a little tap and see if it jiggles. Then it's a cyst. If you kind of get like a thud, that's probably solid. So once you've opened it, if it's a solid tumor, that's your standard approach. Describe the cut surface, take representative sections, including the capsule and any areas of note, hemorrhagic, necrotic regions, cystic areas, things like that. But if it's kind of a big cyst or even a multiloculated cyst and you just open it like this, now we're going to have to start thinking about our cystic elements. The thing to consider when looking for cysts to rule out malignancy is we want to look for the wall thickness. Is it pretty uniform and thin, or do you get areas of thickness, thin areas, kind of areas evolving into sort of a solid necrotic region? You're also going to want to look at the lining of the cyst. Is it everything smooth, or do you have those papillary excrescences we talked about? Now, I did mention, like, okay, the ovary is the tumor, but sometimes what you see is like that little piece of ovarian parenchyma, because it's still there, it just kind of gets stretched out. And there's a specimen in lab I'll show where you can kind of see how that plays out. But you might actually be able to identify a remnant portion of ovarian parenchyma. I would say get a relationship, but it's kind of hard to do because it's always just in a specific spot. So you can get a sample of that and to its surrounding structures if you do find it. Usually I will measure how much normal ovarian parenchyma is left. And then you also want to take a look at, again, any sort of relationship between the fallopian tube and the ovary. Here, this is a little misleading. This is from Westra. It makes it look like the fallopian tube is just connected and it's like a bookend for the ovarian cyst. That's really not how it is. Usually you're going to have your fallopian tube attached to the ovary via your mesosalpinx. So it's hard to get like a structure where it's actually showing the relationship between the two. Unless they're adhesed, then you can go ahead and do that. But again, looking for the cyst contents, wall thickness, the lining, look for those papillary projections, hemorrhage material, necrotic material, things like that. Any sort of variegated look, if some areas look like very kind of spongy and multiloculated cysts, and then you have these giant solid areas or these kind of open cystic spaces, be mindful of that and take representative sections. But when you are submitting sections, it's really just going to be one section per greatest dimension of the ovary, right? So the ovary is your tumor. What you received is the tumor. So what you measured as that specimen, that becomes your greatest dimension. So if it's 10 centimeter ovarian cyst, that means you want 10 sections of that ovarian cyst. You'll also want to try to include the relationships if you can. Like I said, this image is a little misleading. And if you can, as you're taking these sections, you want to try to represent the various areas. So here they kind of got the different regions they noticed. You try to get those relationships if you can. And then what you want to try to do is, if you did identify the uninvolved ovary or the normal looking ovarian parenchyma, just take a section of that. And then you'll do your CFIM protocol for your fallopian tube, just to make sure that there's not a carcinoma from that. But these are relatively straightforward. And they're kind of fun. The only thing I would warn you about is watching out for those small cysts. So if it is a multicystic structure, sometimes you open the big cyst, and as you're serially sectioning, there's little cysts in there or smaller cysts that you didn't know about. And if you weren't wearing eye protection, you get shot right in the eye. Not once, but twice. It's kind of embarrassing, actually. So don't do that. Just make sure you're poking your cysts prior to sectioning or defluidizing them appropriately. So I won't have to read this for you, but this is just a representative dictation for an ovarian mass specimen, getting representative sections for that. And then here's our list of CPT codes. These will be more prevalent in your second year when you're looking for CPT codes for the structures you're grossing. You can refer back to this lecture. Otherwise, maybe you'll have memorized them by then, but I won't test you on these. So that is it. That's all I have for female repro, and I hope you are doing well after all that. And I will see you in class /lab. Thank you for your time.